Hello and welcome to our discussion today, which will be on antimicrobial therapy for select infections managed in the outpatient setting. Objectives for this discussion are for you to be able to recommend first-line therapy for the disease states that we are going to discuss. Also, to identify pertinent clinical guidelines that can serve as a reference for you in the future, since evidence will be updated frequently. Part of my job is to point you towards guidelines and strong evidence that you can use in your practice and you can monitor for updates regularly. And finally, overarching, we'll talk about ways that you can incorporate antimicrobial stewardship considerations into practice surrounding using antibiotics for the treatment of discussion of the infections that we're going to discuss, as well as emphasizing when you can be an educator for patients and support the decision when antimicrobials aren't indicated at all. Today we're going to cover five essential groups here, and they're listed for you. We'll talk about Group A, streptococcal pharyngitis, or you may see it referred to as Group A beta hemolytic streptococcal pharyngitis. Lay term would be strep throat. We'll also talk about acute bacterial rhinosinusitis, abbreviated ABRS. We'll discuss community-acquired pneumonia. I'll point you when we discuss this to other guidelines that talk about healthcare-acquired and hospital-acquired and ventilator-acquired pneumonia, but that's beyond the scope of what we're going to discuss today. We'll have some discussion on uncomplicated cystitis or lower urinary tract infection, as well as a few sexually transmitted diseases and their treatment of choice. Again, our approach is going to be a high-level pharmacotherapy overview, and I'll point you in the direction of clinical guidelines so that you are familiar with where to easily find them and be able to apply them in the practice setting. So that's our place of starting. So where do you look for clinical guidelines related to infections and treatment? Well, there's plenty of family practice-based guidelines and general guidelines that you can find, but two that I tend to go to with specialty focus for infectious diseases are the Infectious Diseases Society of America clinical guidelines, which are available at the website cited for you here. If you click on guidelines and patient care, you can then search by organism or organ system, and I'd encourage you to visit the website to become familiar with the types of guidelines that you can access there. They're actually quite reader-friendly in terms of providing an executive summary, and in addition, they have pocket cards available if there's one or two of them that you're interested in having as a ready reference. As we go through some of these disease states, I've taken sort of screenshots of some of these pocket cards to be able to show you what they look like. Also, the Centers for Disease Control and Prevention at the CDC webpage has great recommendations as well. When you go to their webpage, you then click on diseases and conditions, and I find this to also be a good resource for travel health. So if you have patients who will be traveling out of the country and you need to know which vaccines they need to get or whether they require prophylaxis for certain infections, that's a really great place to look as well. So let's get started by talking about streptococcal pharyngitis, Group A strep pharyngitis. So this is taken directly from the Infectious Diseases Society of America guideline on the topic, and I like this because it basically helps us remember that not all sore throats are strep related or bacterial infection, and there are certain features that are more suggested of a strep infection or strep pharyngitis versus one that would be more viral in picture, in which case you would not be recommending antibiotics for that patient. So you can see that the prevalent age population is ages 5 to 15, so school-age children, and it's usually a sudden onset of sore throat accompanied by fever and headache. You may or may not see nausea, vomiting, or abdominal pain. You may have patchy exudates on the tonsils. You may have petechiae of the palate and oropharynx. They may have tender nodes, and typically it's, in our region, in the Midwest anyway, a late fall through early spring presentation. That tends to be the season. Oftentimes you'll have someone have an index exposure as well. So a parent will bring a child in and say that someone in the class that the child is in is out with strep throat. It's a very easily spread infection. If you have someone who has conjunctivitis, coryza, cough, diarrhea, more hoarseness, and more of that viral exanthem type rash, again, those are more suggestive of viral pharyngitis, and it would point you to the direction of evaluating them from that angle. So this flowchart is taken directly from the streptococcal pharyngitis guideline pocket card. So this is an example of the clinical reasoning that you'll see represented there. So if you have a patient that presents with acute pharyngitis, if they have those clinical features that are suggestive of strep pharyngitis, we do a rapid diagnostic test, and those are available in office, and the results come back very quickly. If that rapid test is positive, we refer the patient for antibiotic therapy evaluation. So we would choose an antibiotic to treat them, stating that that's a positive rapid diagnostic, they have the clinical signs and symptoms to back up that test, and we treat them for strep throat. If that rapid is negative and the patient is a child or adolescent, we would refer that specimen then for throat culture. So this is a little different if you have an adult. If the rapid test is negative in an adult patient, we stop there. We don't necessarily recommend referring on for throat culture. This is because the disease state is much less prevalent in the adult population, and if the rapid is negative, our clinical suspicions drop. In the kiddos, however, in adolescents, where the disease state and the disease burden is more prevalent, in the absence of a positive rapid test, but still strong correlation with clinical signs and symptoms, that's when you'd send the throat culture. If you have a patient that has more of those viral type features, again, then it's more symptomatic treatment, explaining to them why they don't need an antibiotic today, and really using it as an education point for antimicrobial stewardship and getting public awareness out there in terms of the development of antibiotic resistance if we overprescribe antibiotics. So if we have someone who then is deemed to need antibiotic therapy for strep pharyngitis, if they are not penicillin allergic, the primary regimens that are recommended are either amoxicillin or penicillin for 10 days. Amoxicillin tends to be a little more friendly due to the fact that penicillin VK is typically a 4-time-a-day regimen, and patients have a hard time complying with that. But if you have a patient that can do it, it's definitely still a great strep drug. Or you can give a one-time IM benzathine penicillin injection, and that should be fine for the entire treatment course. If you do have someone who has a severe penicillin allergy, if it's a non-anaphylactic allergy, they can be treated with a first-generation cephalosporin, so something like oral cephalexin for 10 days, or oral clindamycin, or an oral macrolide like azithromycin or clarithromycin. So again, remembering your first-line therapy for penicillin non-allergic and penicillin allergic patients is an objective for this disease state. This is summarized again for you, similar to that previous slide, but just in table format, reminding you that most of the oral dose regimens are for 10 days. The benzathine penicillin IM is a single dose and it's weight-based, so children under 27 kilograms will get 600,000 units. Anyone 27 kilos or over should receive 1.2 million units, and again, a single dose. From a parent standpoint, that's actually attractive if you have a young children who spits out, or young child who spits out their medication. So while the shot is an injectable and may not seem like a friendly thing to do, for the long haul, it's a nice option to offer some parents as well. And then you see for the penicillin allergies as well, your cephalosporins, clindamycin, and macrolides. Okay, shifting now from the throat upwards in upper respiratory tract infections, we're going to talk about acute sinusitis. I think this first bullet point is a very important one to focus on from an antimicrobial stewardship standpoint, and that's that most acute sinusitis infections are due to viral causes and no antibiotics are needed. In fact, I encourage you to go to the CDC webpage and search for the Get Smart campaign. The Get Smart campaign is a national campaign that serves to try to improve the way that antibiotics are used. And one of their initial platforms was to try to reduce the unnecessary use of antibiotics in upper respiratory tract infections in the outpatient setting because they are so overprescribed. In terms of sinusitis that is in fact bacterial, in adults the most common sources are strep pneumoniae, H. flu, Moraxella catarrhalis, strep pyogenes, and Staph aureus. So looking at this chart here, and again this is lifted from the acute bacterial sinusitis guideline from the Infectious Diseases Society of America, based on major and minor symptoms that can help the clinician rule in a bacterial cause. So in order to have a defined bacterial infection or a defined sinusitis, the patient needs to have at least two major or one major and two or more minor symptoms. I'm not going to read through all of them, but you can see that they make sense in terms of patients who are presenting with sinus pain, headache, ear pain, cough, purulent discharge, etc. Here again, you see an example of one of the flowcharts from the clinical pocket card for sinusitis from Infectious Diseases Society of America. Again, I really like the pictorial and clinical decision tree and the way that these are presented. Essentially, what this describes is if you have a patient with persistent and not improving infection greater than or equal to 10 days, and I think that's a good marker for patients who have viral infections. Typically, those will resolve by about 10 days. So if someone comes in and it's day 2 or 3 of their infection and they're just starting to feel a little crummy, really coaching them through and not providing an antimicrobial is the right thing to do. Or if they have greater than or equal to 3 to 4 days of really severe symptoms or worsening or double sickening. So, today you feel twice as bad as yesterday, and yesterday you felt twice as bad as the day before, etc. So you really are on a steady decline for greater than 3 to 4 days. Then there comes a point of evaluating for the risk of antibiotic resistance. And if you look down at the bottom of this chart in the corner, you can see sort of those bullets for antibiotic resistant risk. Some of the most common, I would say, that we see around here are kiddos in daycare who are exposed to drug-resistant strep pneumoniae, prior antibiotics within the last month, and that's something that if patients are taking recurrent courses of antimicrobials, then those pathogens can develop resistance. And immunocompromised patients, I think, are always a big one as well. So then we go down the line of if they do have the risk for antibiotic resistance, it's second line antimicrobial therapy, and we'll show that later. But for the purposes of this course, we're going to focus on first line antimicrobial therapy. And then it's a reassessment for improvement. So if you notice, it's improvement after 3 to 5 days. And I think that's an important counseling point as well. Telling your patient that, you're going to start your antibiotic today, but you're probably not going to feel better for up to 3 to 5 days. It's a more of a slow improving process. I think teaching them this aspect gives them more faith to continue the antibiotic course and complete the whole course, rather than calling back and saying, I want something else, and then the provider broadening the spectrum, etc. And then essentially, if they do have improvement, it's a 5 to 7 day course of therapy. If it's worsening or no improvement after that 3 to 5 day point, then it's reevaluation and potential switching of antimicrobial therapy, or potentially sending them to an ENT specialist and doing imaging and things of that nature. So again, this is a really nice flow chart to help guide practice based on specific patient factors. This table is again taken from the guidelines, and it provides a nice summary of treatment recommendations for bacterial sinusitis. You can see that the first line therapy in a patient who is not allergic to penicillin is amoxicillin clavulanate. And essentially, if we go down the line and evaluate if a patient has a severe beta-lactam allergy, that's where our doxycycline comes in, or potentially one of the quinolones that has strep pneumoniae coverage, like levofloxacin or moxifloxacin. If patients do meet those risk factors for antibiotic resistance, or we're dealing with someone who's failed the initial therapy recommendation, that's where again you might see either higher dose amoxicillin clavulanate, or again shifting to a quinolone that covers strep pneumoniae. Finally, if you have a patient who has a very severe infection that requires hospitalization, that's where we might see that shift toward the quinolone again, or perhaps an intravenous third generation cephalosporin like ceftriaxone. And the reason for that would be for the expanded strep pneumoniae coverage, as well as some better coverage against some of those respiratory gram negatives. All right, shifting down the respiratory tract now, we're going to have a short discussion about community-acquired pneumonia. And you can see that several of the pathogens that are commonly found in community-acquired pneumonia patients are the same as the ones that we just discussed in terms of bacterial sinusitis. So Streptococcus pneumoniae, gram-positive cocci, colonizes the nasopharyngeal flora in about half of the population of healthy adults. Other pathogens that are common, Haemophilus influenzae, Moraxella catarrhalis, as well as we now have some of the atypical organisms come into play for community-acquired pneumonia. Mycoplasma pneumoniae, Chlamydia pneumoniae, and Legionella species are the most common atypicals that we see. Although relative to the other pathogens, atypical community-acquired pneumonia is less common. The guideline, the Community-Acquired Pneumonia Guideline by the Infectious Diseases Society of America, as well as there are others in collaboration with American Thoracic Society, basically provide scoring tools that help triage patients appropriately. Things like the CURB 65 tool to help decide whether or not the patient should be admitted to the hospital or treated in the ambulatory setting. We're not going to focus on those scoring triage tools because our focus is going to be for those patients who qualify for outpatient treatment. This is again a table that's lifted from the CAP pocket card, just to show you and give you an example about the types of information that you can find there. And I like how it separates out the patients by class and makes it very clear how we would evaluate patients and what agent we should use first line. So if you have a previously healthy patient who hasn't had antibiotic therapy in the previous 3 months, essentially we're looking at macrolide or doxycycline monotherapy. If you have patients with comorbidities, and a whole bunch of them are listed for you there, that's where we may turn to a fluoroquinolone with strep pneumoniae coverage or a beta-lactam plus a macrolide, and you have some of the options listed for you there. So it becomes then still an oral regimen. However, you may be taking 2 drugs in the case of the beta-lactam combined with the macrolide. If you live in a region where you have high rates of strep pneumoniae that are macrolide resistant, then the first line recommendation is a respiratory fluoroquinolone. So again, one with strep pneumoniae coverage, or again, that beta-lactam plus a macrolide or doxycycline, and there are some also alternative beta-lactams listed for you there. You can see the little star on the bottom that if a patient's received a macrolide in the previous 3 months, then we would go right away to a fluoroquinolone. And if they'd received a fluoroquinolone in the past 3 months, then your first line would be the macrolide. So I think that's kind of, again, emphasizing the importance from an antimicrobial stewardship standpoint of taking a really good antibiotic history in your patient to help them, or to help make the decision on what to treat them with this time. All right, so we're going to jump now out of the respiratory tract altogether. We've done pharyngitis, we've done rhinosinusitis, and we've done community-acquired pneumonia. So now we're going to talk about uncomplicated cystitis or bladder infections. So in contrast to the pathogens that you saw in the respiratory infections, we're dealing with a different pot of bugs for the most part here. So most commonly in UTI, you'll see our Enterobacteriaceae. And in fact, 75 to 90% of UTIs, based on where you look at for prevalence, will be caused by E. coli. So that's our primary bug. And you can see some of the other Enterobacteriaceae, Proteus, Klebsiella, Enterobacter, and then some flora, some staph flora like Staph saprophyticus, and then in more rare cases, in patients with underlying risk factors, you may see Pseudomonas, and as well Enterococcus, kind of keeping in mind that Enterococcus can be intestinal flora, so there can kind of be cross-contamination, and that's how Enterococcus can get introduced. So uncomplicated cystitis is defined essentially as a lower UTI, so not up in the kidneys, that would be pyelonephritis, but a lower UTI in otherwise healthy women of childbearing age. If you fall outside of that, if you would have, for example, urinary obstruction, be elderly or a male, then you don't fall into this guideline, this aspect of the guideline, and you would be more classified as a complicated urinary tract infection. Likewise, if you have a catheter in, then we'd be evaluating you for a catheter-associated UTI. So when we talk about uncomplicated cystitis, I think it's important to keep that definition in mind, that these are folks who have no urinary anatomy that's abnormal, and they are typically otherwise healthy women of childbearing age. In terms of treating uncomplicated UTI, again, this is lifted from the flowchart of the pocket card, and I think it's a nice, helpful summary. You can see that there are essentially 3 first-line agents that are your choices. One would be nitrofurantoin for a 5-day course, and if you recall from our discussion of nitrofurantoin in our antibiotic review lecture, there are some patients that we have to use caution with it, primarily patients who have reduced renal function of creatinine clearance of less than 50, because essentially then that drug doesn't get great delivery to the lower urinary tract and it doesn't get good enough concentrations. Another equally good first-line choice would be TMP sulfamethoxazole, your Bactrim double-strength tablet, and that would be for a 3-day course. So you can see already that this isn't something that we're treating for 14 days. And if you are seeing patients who are being treated for that long for an uncomplicated cystitis, that really is, again, not a great element of antimicrobial stewardship. We want to minimize exposure, give the right drug for the least amount of time in the hopes of treating the infection adequately and preventing bacterial resistance. And finally, the last choice is a single dose of fosfomycin. So any of those three are considered first-line options by the guidelines. If for some reason you can't use one of these preferred agents due to allergy, contraindication, renal function, etc., they give you alternate choices there. And that's anywhere from 3 to 7 days if you're using a beta-lactam, or again, 3 days for a fluoroquinolone. And I think that it's really important to note that fluoroquinolones are not first-line agents for patients presenting, especially with their first uncomplicated UTI. It's very easy to just prescribe ciprofloxacin for 3 days. However, again, from an antimicrobial stewardship standpoint, we can use an agent that has a narrower spectrum, and in the case of nitrofurantoin and fosfomycin, target the urine only to help try to reduce that selective pressure and the development of resistance. So fluoroquinolones aren't first line for this infection type. Okay, so shifting now to the final disease states that we'll be discussing are the sexually transmitted infectious diseases, or STDs. The CDC is really the organization within the U.S. that has the workhorse guidelines for these, and great resources in addition to the guideline, great patient resources, education resources, etc. They do have several reference tools on their website, all available for free, including apps for the clinician to download onto their phone to help guide evaluation and therapy. They have a clinical pocket guide. They have a wall chart that can be hung in patient exam rooms for education. And so the excerpts that follow in the slides that are upcoming show you some of the information that you'll find in the guidelines. I'm not going to focus on special populations or treatment failure. We're really going to basically cover that 101 level of upfront therapy. And if you have a special population or treatment failure patient, you can refer to the guideline. So the four that we're going to discuss in brief are gonorrhea, chlamydia, syphilis, and genital herpes. And again, the goal of this lecture is not to be a pathophysiology review. So if you need a pathophysiology review of these disease states or any of the ones that we've spoken about today, I'd refer you back to the guidelines or full text guidelines themselves. But gonorrhea, as you probably know, is caused by Neisseria gonorrhoeae, which is a gram-negative intracellular Diplococcus pathogen. And really, there's really only one drug therapy that's recommended first line, and that's IM ceftriaxone. So if you have a patient who is positive for uncomplicated gonococcal infection of the cervix, urethra, rectum, or pharynx, the ceftriaxone 250 milligrams IM times 1 plus azithromycin 1 gram PO times 1. And when we get to the next slide, you'll understand what that azithromycin is covering. I provided you with some examples of some of the fact sheets that you can get on the CDC webpage in terms of patient education as well. And again, there's just some really good information available both for clinicians and patients at no cost. So this is why you will see azithromycin for any patient who's being treated for gonorrhea, because patients infected with gonorrhea are often co-infected with chlamydia. Therefore, practice is that a patient should receive therapy to eradicate both organisms concurrently. One thing that I didn't mention about gonorrhea on the previous slide is that there's something called the CDC Threat Report that was published in 2013, and essentially it's a list of pathogens and a summary of antimicrobial resistance and outlines pathogens that are at risk or that are at high levels of resistance, and gonorrhea actually made that list. So that's why we used to be able to say that we could potentially use a quinolone to treat gonorrhea, but that isn't the case anymore. But what we still do is treat anybody who is infected with gonorrhea empirically for chlamydia. And there comes in the azithromycin. So Chlamydia trachomatis is the most common chlamydial pathogen. It's a gram-negative obligate intracellular pathogen. And again, I've starred that azithromycin 1 gram orally in a single dose. Doxycycline for 7 days is an alternate regimen, but obviously for adherence reasons, that takes a little bit more versus a single dose that can be administered at the point of care. Again, there are specific recommendations for treatment in pregnancy, so if you would need to know that, you can look them up in the guidelines. Shifting now to syphilis, which is caused by Treponema pallidum, and that's a gram-negative spirochete. I think understanding syphilis, you need to understand sort of the differing presentations based on timeline. So primary syphilis is the initial lesion. So an example presentation of that would be a chancre or the ulcer lesion on the site of infection, such as the genitals or even the oropharynx. 3 to 6 weeks after that primary lesion, which does typically heal on its own, so patients may not present to you in that setting, but most will, especially men with concerns for a lesion in the genital region, tend not to ignore it. But you could have a patient who doesn't present in that primary stage. 3 to 6 weeks after, the stage then converts to being secondary syphilis, and that presents with a different looking rash. So it's more papillosquamous. Patients can have some lymphadenopathy, and they can have mucus patches or condylomata. So I think that understanding sort of the different looks of syphilis as we go through the different phases is important. And you can always look up some images of these if it's something that you're not familiar with. In tertiary syphilis, about a third of untreated patients will progress within 20 years of their primary infection to a tertiary syphilis, which means essentially 2/3 will not. So again, not everybody makes it into this stage. But if they do, you can see gummatous lesions or potentially cardiovascular valvular disease. You can actually have syphilis endocarditis. Latency occurs when essentially this organism isn't manifesting a clinical disease, but the only evidence is a positive serologic test. We classify these patients as early latent if it's less than 1 year, or late latent if it's over 1 year duration. And then finally, there's neurosyphilis, which can occur at any stage of infection if the organism invades the central nervous system. So it can be early within months to a few years, and what you're likely to see there is more of a meningitis picture or ocular involvement. Or it can be late, which is decades later, and it is rare, but that can present as a general paresis, ocular involvement, and an elderly patient is typically the one that you're looking at for neurosyphilis or late neurosyphilis. In terms of treatment, it all goes back to the stage of syphilis that the patient presents for treatment. So if it's a primary, secondary, or early latent syphilis, those patients should receive benzathine penicillin 2.4 million units IM as a single dose. Again, this goes back to our early lecture on the beta-lactams talking about the differences in bicillin LA versus bicillin CR and knowing the difference and not interchanging them, because we would be undertreating a syphilis patient if we did. If a patient presents for late latent syphilis, or if we have latent syphilis of unknown duration, or a patient with tertiary syphilis but no neurologic involvement, they receive the same penicillin benzathine injection, but that's once weekly for 3 weeks for a total of 7.2 million units. At any stage, if a patient has neurosyphilis or CNS involvement, we usually shift them to IV penicillin G, so given intravenously versus intramuscularly. You can, as an alternate, do daily IM procaine penicillin for 14 days. So that would be the Bicillin CR, the procaine, not the LA, for 2 weeks. But from an adherence standpoint and ensuring that a patient is actually going to do that for the entire 14-day course, I think you see many patients admitted and given IV penicillin G. If you have someone with a penicillin allergy, we can do a skin test to confirm. We can actually desensitize these patients to penicillin, or the guidelines do recommend some alternate agents. So I'll refer you there if you do have a patient with syphilis that you need to treat who happens to be severely penicillin allergic. One thing I wanted to mention in terms of the treatment of syphilis is the Jarisch-Herxheimer reaction. This is a self-limited reaction to antitreponemal therapy, and it really occurs within the first day or so after you start therapy, and it presents with fever, malaise, nausea, vomiting. Some patients can have chills, and they may have kind of an exacerbation of their rash. What I want to emphasize again is, like the amoxicillin non-allergic rash, we don't consider the Jarisch-Herxheimer reaction an allergic reaction to penicillin. So we wouldn't label this patient as being penicillin allergic and not being able to receive a penicillin in the future. You more commonly see this reaction in patients who have early syphilis, presumably because the bacterial burdens are higher, and so they're at increased risk for having this reaction when we expose those bacteria to the penicillin and kill them. And also of note, pregnant women should be informed of this possible reaction because it can precipitate early labor, and so they should be in touch with their obstetrician if problems develop. Okay, so now we're going to go to we basically just covered all of our sexually transmitted infections that were caused by bacteria that we're going to discuss. And now we'll discuss genital herpes, which is caused by a virus. So we're going to discuss first clinical episode treatment, episodic treatment, and chronic suppressive therapy. And one thing that is different about genital herpes treatment compared to the other sexually transmitted diseases that we discussed is that our treatment for genital herpes is not curative. It's suppressive, and the goal is to reduce the number of outbreaks and prevent the spread to partners. So when you have a patient that presents with genital herpes and it's their first clinical episode, note that in the U.S. it's predominantly HSV2 with some HSV1. You see the recommended first-line CDC regimens here. I put a box around valacyclovir simply because that's a BID regimen, and that tends to be the one that I see used the most simply for an adherence reason. If you go and look at the second recommendation of acyclovir 5 times a day, most patients will not be able to do that in a meaningful way that will help get their disease under control. If you have a patient who has incomplete healing of their lesions after that initial 10 days of therapy, they should be instructed to follow up, and therapy can then be extended for longer. So that last slide was referring to the primary episode, the first episode of presentation. Some patients may or may not present at the first episode. But what the CDC then also stratifies out is episodic therapy. What episodic therapy is when a patient has an outbreak. So they have their first prodrome of the lesion or their first lesion erupt. They start treatment. So the problem with this is that it does require initiation within a day, so 1 day of lesion onset, to have a beneficial effect. The goal of episodic therapy is to shorten the duration of the outbreak and potentially make the patient have fewer lesions in the outbreak itself. So this is the patient recognizes the first lesion or the prodrome of the lesion and starts treatment right away. So the recommended regimens for episodic therapy, you can see the duration is shorter. So it's not a full 10-day course, but the duration is shorter. The viral burden tends to be lower in subsequent outbreaks than it does in the initial one. And that's one of the reasons why shorter courses are able to be accomplished. There's a whole laundry list, and there's the 3 different antivirals for herpes that we discussed in the antiviral lecture. So understanding, again, I think the difference that this isn't a 10-day therapy is the key point here. For patients who have greater than 6 recurrences or outbreaks per year, suppressive therapy is recommended. The goal of suppressive therapy is to decrease the number of flares per year. And if you look at the data, it does reduce frequency by about 70 to 80% in those patients who have more than 6 recurrences per year. There are, again, the 3 HSV drugs listed as options. The one that I'd like to note is the 500 milligram dose of valacyclovir has been shown to have decreased efficacy compared to other regimens in patients who have greater than 10 episodes per year. So if you do have a patient who has greater than 10 episodes per year and the choice is to use valacyclovir to treat that patient, it needs to be at the 1 gram dose versus the 500 milligram dose. Annually, patients who are on suppressive therapy should be reevaluated and really discuss the need for continued suppressive therapy. So they may have a trial off therapy because of the risk of the virus becoming resistant, as well as the hope that we can wean them off therapy and not have them exposed to this drug. So in summary, hopefully by presenting a few common outpatient infectious disease states, you can appreciate the role of antimicrobial therapy within the context of a patient's therapy. I think this also helps you gain an appreciation for the importance of staying up to date. Given that infectious diseases is really a dynamic field and things are constantly changing because the bacteria are constantly getting smarter, new drugs are coming to the market, hopefully some of these clinical guidelines that I've directed to can serve as the foundation for your continued lifelong learning. Finally, I'd like to challenge you to always apply the principles of antimicrobial stewardship in practice, both from a standpoint of recommendations for using antibiotics, but also from a patient and provider education standpoint. It's up to us to hold each other accountable as well as support other colleagues if they choose to not prescribe an antimicrobial, and really use that as a teaching point with our patients so that from the bottom up, people understand that it's everybody's role to preserve the antimicrobial arsenal. So with that, I'd like to again thank you for your attention, and if you have any questions at all regarding the content of this presentation, please don't hesitate to reach out and be in touch.